Hello, everyone. I'm going to speak today about CRRT, which stands for Continuous Renal Replacement Therapy. First, we'll take a quick look on some basics, kidney function, what means by acute kidney injury, and then the principles of CRRT, and the CRRT prescription and the anticoagulation of the circuit. So we'll start the basic, just a piece of information about the kidney, which receives 1.2 liter of blood each minute with a sum of 72 per hour. And as we know that EGFR, which is the measure of the kidney function, is calculated according age, gender, and race, with a special formula. So we have the kidney function is the ultrafiltration, which is being run by the glomeruli, and also excretion and reabsorption by the kidney tubules. It was mentioning that the glomeruli filtrates up to 170 to 180 liters and reabsorb 168 to 178 back out of them. So the net filtrate is 2 liters per day. The proximal tubule is doing function of reabsorption as well as secretion. So reabsorbs sodium, glucose, potassium, amino acid, bicarb, phosphorus, and urea, and secretes hydrogen and foreign substances. Its function is to concentrate urine through a countercurrent mechanism, and also the ascending loop of Henle is through the active transport of sodium, while the descending doing water reabsorption and sodium diffusion. This convolute tubule reabsorbs sodium, water, and bicarb, and secretes potassium, hydrogen, urea, and ammonia. Collecting ducts reabsorbing water and reabsorb sodium, potassium, hydrogen ion, and ammonia. So just to summarize, the kidney function is responsible for electrolyte balance, acid-base balance, excretion of drugs, toxins, and urea creatinine, erythropoietin formation, secretion, and blood pressure regulation, and activation of vitamin D. In intensive care unit, we have many reasons for the kidney function to drop, including increased production of creatinine because of the breakdown of the muscles in critically ill patient, and also drop in urine output for many reasons, which could be pre-renal, renal, and post-renal. Quickly, the pre-renal cause include dehydration, hemorrhage, congestive heart failure, liver failure, any cause of shock, non-steroidal and ACE inhibitors cause decrease of the blood flow to the glomeruli as well. Intrinsic causes of ischemia, drugs, gram-negative septicemia, acute interstitial nephritis, glomerulonephritis, vasculitis, and hypertension. Post-renal cause, compression on the ureter or the kidney pelvis for any reason, and also abnormal anatomy, especially in post-transplanted kidney, enlarged prostate, tumors, tumor or enlarged ureters, bladder, or urethra. We have two types of classification of AKI. The first is the KidneyGo classification, which is classifies acute kidney injury into stage 1, stage 2, and stage 3. Stage 1 which increase in the creatinine from 1.5 to twofold from the baseline, or drop in urine output below 0.5 ml per kg for 6 hours. Stage 2 is the increase of the serum creatinine from 2 to 3 folds, or drop in urine output less than 0.5 ml per kg for 12 hours, while stage 3 is more than 3-fold increase in creatinine or urine output less than 0.3, or basically speaking, anuric patient. And when we start a patient on renal replacement therapy for any reason, it is considered as AKI stage 3. This is for KDIGO classification. Another classification is rifle. In rifle, so we take risk of the kidney injury, and then failure. So these are the same as KDIGO classification. And in rifle criteria, we add loss, which is persistent acute renal failure or complete loss of renal function more than 4 weeks, and end-stage renal failure when the kidney function or like is not functioning for more than 3 or 4 months. After we identify the acute kidney injury, so the basic of treatment, or the aim of treatment of kidney function of the AKI is to restore the fluid balance, is to remove the waste, and also to maintain the patient hemodynamic stability and restore the acid-base balance. That's when the indications of CRRT comes. So for renal causes, high urea, hyperkalemia, not responding to medical treatment, severe metabolic acidosis, refractory pulmonary edema that does not respond to diuretics, non-renal cause, congestive heart failure. If sometimes we need CRRT for removal of toxins or temperature control. Removal of inflammatory. This is what is historical. It's not an indication now. Rhabdomyolysis and lactic acidosis are the non-renal indication for dialysis. These are the group of drugs that can be removed by dialysis. So basically, if the drug is highly protein bound and lipophilic, so it is less likely to respond to renal replacement or to be washed out with dialysis. So this group of medications are digoxin, very high protein bound, tricyclic antidepressant, phenytoin, glycoside, beta blockers, benzodiazepines, macrolide and quinolones, and warfarin. So this cannot be dialyzable. While other medications like lithium, methanol, ethylene glycol, salicylate, barbiturates, metformins, aminoglycosides, metronidazole, carbapenems, and penicillins. These are a group of medication that can be dialyzed if dialysis is needed for it. So these are the concepts of renal replacement therapy or continuous renal replacement therapy. So waste removal and water removal. So waste removal by diffusion, which means that the waste is being moved from an area of high concentration to an area of low concentration. The other mechanism is convection. So in convection, so we give a solvent, and then we take out the solvent from the blood. So this solvent will take with it the waste. So like movement of the molecule within the fluid dragged by a solvent. And the other mechanism of CRRT is water removal. by ultrafiltration. So we have waste removal, water removal, waste by diffusion and convection. So diffusion and convection and ultrafiltration, those three are the basic of dialysis or filtration or kidney replacement. The advantage of continuous renal replacement is to maintain the patient hemodynamic. So because the blood flow is slow blood flow, it does not cause a hemodynamic instability or drop in blood pressure in patients, especially those who are already hemodynamically unstable. The modalities of renal replacement is ultrafiltration, slow continuous ultrafiltration, and also continuous veno-venous hemofiltration. So when we say C here, it stands for the principle of continuity, which means the renal replacement therapy is continuous, and VV because we are taking from the vein and we return the blood back to the vein, so veno-venous. And then H stands for hemofiltration. Then diafiltration, sorry, hemodialysis, which is CVHD. And then if we have hemodiafiltration, so we combine the both mechanism of 2 and 3. So we'll continuous veno-veno hemodiafiltration. So for continuous hemofiltration is a part of convection therapy when we give solvent and then drag the waste by this solvent. And CVVHD is basically a diffusion therapy when there is counter current fluid pass and the waste is being moved from higher concentration in the blood to a low concentration in the dialysate fluid. These are some of the CRRT machines. This is Verenius 1. So it, according to the company, the machine may look different, but basically the principle is the same. Each machine have a filter and pump, multiple pumps actually. So it depends on the mechanism that we use, either ultrafiltration or CVH or CVHD or CVHDF. So we'll start with the ultrafiltration. So in ultrafiltration, we just remove fluid. So we take the fluid from the patient. So we don't use any dialysate or any fluid substitution. And the only pump will be working in the machine is the ultrafiltrate pump. So it's just like moving a fluid along a pressure gradient. So this is it's a very simple principle. So we just get the blood from the patient through the arterial line, or it's the red side of the vascular catheter. We have only the ultrafiltration pump, and the fluid is being going back to the blood is going back to the patient, and the filtrate is being collected. So it's very simple, and we used only just a pressure gradient. The next one is the convection. So in convection, in this method, the solute is passing through a semi-permeable membrane with water. So we use the pre-dilution, or we give a fluid before the filter, and then we'll take this fluid out. So this fluid or water is a solvent which drag the molecule that we need to clear it. So the principle used for CVVH is the ultrafiltration and convection. So we can use it in uremia if there is acid-base imbalance, electrolyte imbalance, and also it can be used for fluid removal. The pump we used pre or post substitution fluid pumps, fluid, and the pump we use pre and post dilution pump. So this is how it look like. So you have the blood comes from the patient, and then we put the substitute. The substitute or the solvent will drag the waste and will go to the filtrate, and the rest of the blood is being returned back to the patient. And then we have the continuous veno-venous hemodialysis, and this method depends on the diffusion principle. So in this method, we take the blood from the patient and going to the filter. Before going to the filter, there is a counter current. So dialysate is passing and is passing around the filter. So the waste or the solute is being moved from the area of high concentration in the blood to the area of low concentration in the dialysate fluid. So the solute is moving through the semi-permeable membrane from high concentration to area of low concentration. And in this one, we use the pump for dialysate and also pump for the filtrate. This is how it look like. So you have a blood coming from the patient, the pump of the blood going to the filter, and on the other side, like a counter dialysate is being passing around the filter. So the solute is being moved from the blood to the dialysate, which will form the filtrate. And we have the most commonly, used most commonly the continuous veno-venous hemodiafiltration. So both of the mechanisms are being used with the principle of diffusion, where we use the dialysate or counter current dialysate, and we used pressure for ultrafiltrate to take more fluid, and also use the principle of pre-dilution or substitute. So we can remove solute also by convection. So this is the most commonly used method in ICU, continuous veno-venous hemodiafiltration. And this is how it look like. So you have here the dialysate, and you have also the substitute. Substitute can be a pre or post filter. So this is when we use the substitute pre the filter, and this is when we use post filter. Then we'll come to the measurement of the therapy dose. So this is the when we start a patient on dialysis and intensive care, the nurse will give you a form to complete. The most important point at this form is to determine the dose of the therapy for the patient. So the therapy dose is a quantity of blood being purified, and the clearance represents the volume of blood cleared of a given solute. You decide the amount of the therapy based on the patient weight. So the total of ultrafiltration rate, you will say it is milliliter per kg per hour. And usually in the chart, there is a from 25 to 50, and the most likely we prescribe 35 ml per kg per hour. But if we are using a pre-dilution means we are giving a fluid before the blood is going to the filter, which will affect the clearance. It will cause a reduction in the clearance. So at this stage, we may consider increasing the therapy by 15 to 40% if we use if there is a pre-dilution method. I'm going to talk about the anticoagulation. So We have coagulation active if we know that when we take the blood out of the circulation, there is the cold surface of the circuit will cause coagulation cascade activation. And this will lead to reduction in the renal dose. So they also lead to blood loss of anticoagulation factor which being consumed in the filter or in the circuit, and also the filter, the pores inside the filter will be clotted and decrease the filter lifespan. And also sometimes you have to change the line because it would be already clotted. So we have two types of anticoagulation. It is either systemic anticoagulation when we give the heparin or Flulan to the patient, or regional or extracorporeal anticoagulation, which can be achieved by heparin and or citrate. If we talk about heparin, it's easy, low cost, and shorter half-life. However, higher risk of bleeding and also risk of heparin-induced thrombocytopenia in 1 to 5% of population. Low molecular weight heparin, I did not see it used in patient in ICU, so it is enoxaparin, simple to use. You don't need to check INR or ABTT. It has a longer half-life, and there is no available antagonist for enoxaparin. Prostacyclin, prostaglandin antagonist, so it can cause potent vasodilatation, and it has antiplatelet effect, so it is unlikely to cause hemorrhage. However, it can cause hypotension, increased in intracranial pressure, and also expensive, and there is no antagonist. And one of the most commonly used is citrate. So citrate is being added to the extracorporeal circuit before the blood is being before the blood is entered the filter. The principle of citrate is that it will bind to the calcium and stop the coagulation cascade. So we will form calcium citrate, which will be removed by the filter, and 60% of it, and the remaining 40% of the calcium citrate will be reinfused into the body and metabolized by the liver, muscles, and kidney. So when the citrate is being metabolized, it released by carb. So 3 to 4 millimole of citrate per liter of blood. This is the dose prescribed in CRRT protocol. And our target is to reach ionized calcium 0.2 to 0.35 millimole per liter. Post-filter calcium also is being monitored to ensure adequate anticoagulation and allow citrate dose adjustment according to the predefined module. Because we have consumed the calcium of the body, so if we return the blood with very low calcium, it will affect the patient. So we have to replace this calcium. So before the blood enters the body again, we give calcium chloride. So we can give the calcium chloride either into the central line or in the dialysis venous line itself. It worth mentioning that when we use citrate, there is a different dialysate or fluid is being used with the circuit, which should be no calcium. And usually we start calcium chloride replacement by central line or inside the venous side of the circuit after the filter at 40 to 60 ml per hour. Advantage of citrate. So the citrate is only being being used in the extracorporeal circuit, so it does not, although it's part of it is being metabolized or entered in the body, but it is metabolized. So most of the citrate is being entered outside the body, enters the circuit outside the body, and being removed in the filter. So it is also easy to monitor the calcium. So we need to take an ABG to see the ionized calcium level, and also we'll need to take the calcium level after the filter to make sure that we are achieving adequate anticoagulation. So I want to just to make it clear again. So we take 2 samples of the blood, 1 sample just after the filter, and this one will check the calcium level, which should be 0.2 to 0.35 millimole, just to make sure that the anticoagulation is adequate. And we take another ABG to see the ionized calcium level. Okay. Also, when we send the blood, we'll take the total calcium level to say that, to make sure that there is no citrate toxicity in the body. So citrate toxicity, because citrate, it is a weak acid, it can cause acidosis. So usually you'll find the patient has low pH, high lactate, but normal bicarb or high bicarb, and also normal CO2. So you don't know from where the acidosis came. And if you check the calcium, the total calcium will be high, which means that this patient has citrate toxicity. How to monitor the citrate? So we said that we take 2 samples, one from the arterial line and another one from the return or the blue line. Calcium ratio, we measure the calcium ratio, like total calcium to ionized calcium, which should be no more than 2.5. Initially, we do this after 6 hours of starting the renal replacement therapy, and then every 24 hours. If the patient has liver impairment, like degree of liver impairment, we can do it every 12 hours. But if the patient has decompensated liver failure, we can't use this, because the citrate will accumulate in the body, as the liver is the main site of metabolizing citrate. So the most reliable sign of citrate accumulation is a ratio of total to ionized calcium with a cutoff of 2.5. More than 2.5 means that there is some citrate accumulating into the body. And as you said, it is due to reduced clearance by the liver. So if you find unexplained metabolic acidosis in a patient on CRRT and citrate, so check citrate toxicity. If you find that the calcium is high and you are sure that there is citrate accumulating into the body, so you can manage this by doing one of the following. Decrease the blood flow, because when you decrease the blood into the filter, so it will decrease also the citrate flow or the citrate coupling. Or you can increase the dialysate rate, so which means that you are removing more of the citrate. Also, you can target less citrate concentration within the filter, or after when you find you can decrease the citrate infusion. We said that we start with 40 to 60. We can decrease the citrate infusion. These are some tables to help about managing calcium and citrate. So first, check the result of the ionized arterial ionized calcium. If it is less than 1, then check the calcium in the filter. If it is more than 0.5, it means you need to increase the citrate dose, and so on. So here the target is this one in the middle. So you need arterial calcium or arterial ionized calcium between 1 to 1.3, and you need the post filter or the calcium in the blue line to be between point 2 to point 0.5. Um, So here the calcium ratio again, it's this, if you find that the calcium ratio is less than 2.5, that means it is normal. So you can check once daily, and you can check the level 12 hourly if the patient have some degree of liver impairment. Um, if the calcium total calcium to ionized calcium ratio is more than 2.5, so it could be some sort of toxicity. So we can do this by reducing the pump speed. Also, the citrate pump. Um, if the calcium ratio is at 1 hour remains above, and then we can repeat testing, and probably we can double the dialysate flow. If it is still high, um, we can even stop the citrate infusion for some time.
So everyone, thank you for coming to this sort of talk today. So I'm going to talk about who benefits from renal replacement, and it's going to be more not necessarily from an ITU perspective, but it's going to be, I suppose, to give you an idea about who we actually dialyse in renal, because there's various classic jokes about who we dialyse in renal and that we seem to dialyse everybody, but that's not quite accurate. So I want to talk about who we actually do dialyse. Um, I think this quote is great, and I think this should be engraved on every ITU's door. Um, basically, I think this is applicable to a lot of what we do in medicine as well. There's all this. We can put any patient on a machine, we can keep them alive for days, weeks, but actually, if we're not, achieving, quality of life at the end of that, then what's the point? And you know, I think that's just as applicable to patients on dialysis, really. And I'm going to talk a little bit about that and why that is. Um, so, um, as I say, I just need to break this down a little bit further and really stress there's a difference between patients that start on dialysis for acute kidney injury, which is probably most of the patients that you guys see. There's those that start on it for reaching end stage renal disease, for sort of chronic kidney disease. Um, as I say, acute kidney injury needing acute renal replacement is a very different beast to end stage renal disease, and it's important that we think of those a bit differently. A patient with previously normal renal function who gets an acute kidney injury and then maybe ends up on ITU is most likely actually to regain their kidney function, depending on how severely ill they've been, and they should get back to baseline. And that, I think, needs to be sort of thought about in terms of would we offer this patient renal replacement therapy or not. And generally, if we think this is something that's going to recover, then obviously we would. On the other hand, someone who's got quite advanced chronic kidney disease, maybe an EGFR of sort of 10 or 20, who then develops an acute kidney injury, they're a lot less likely to actually recover back to independent renal function. And I'll talk a bit about why that's important in a minute. So basically, part of my job, I see these patients and outpatients who have advanced chronic kidney disease. The kidneys are still functioning adequately, but their function's getting lower and lower, and they're heading towards end stage failure, really. And then at that point, their options are different modalities of dialysis, or reaching the end of their life. So it's important that hopefully it'll be useful for me to tell you how I go about making those decisions and guiding the patients through that, really. So I'll talk a bit about what happens when these patients see me, and then how these decisions are made. Um, so I think this is probably one of the most I think it's probably one of the most important graphs that I can show. I'm sure normal people have favorite graphs, and this is probably one of my favorite graphs. Um, so looking at this, I want you to focus on just the grey bars first of all. But in grey is the additional patient years on average that patients get from starting dialysis. So what I'm trying to sort of show with this is that dialysis is not some miracle cure. It will not, if you start dialysis tomorrow, you will not live a normal length of life. If you look around the 25 bar, 25 to 29, if you end up on dialysis, you just get another additional 15 years, which is pretty rubbish if you ask me. You're going to be lucky to see your mid 40s, and it's an average, but you'd be lucky to see your 50s. But contrast that really as you go much further down the graph towards the bottom, and you actually see the sort of diminishing returns of being on dialysis in terms of length of life. By the time you get to sort of age 75, if you start on dialysis as an end stage, you reach end stage, your kidneys aren't going to recover, you start on dialysis, maybe you've got another 2 years of additional life compared to someone else that might have another 4. And then really it sort of gets into the grey zone of when you're 80. Actually, I see patients in clinic who are very well otherwise, but their kidneys are failing, and starting on dialysis in your 80s, on average, you might get another 6 months or a year of additional life. And that's if you're good. If you've got other comorbidities, there's real questions raised and being investigated about, is there any benefit of being on dialysis? Does it actually just diminish your quality of life and give you kind of minimal, if any, additional length of life? And there's research we're involved in Leicester that's sort of answering or trying to answer that question. The other important bit on the graph is obviously the red lines, which are the additional years from transplant. And again, if we look at a patient aged 25 to 29, if you get a transplant, that will give you another 20 odd years of life on top of it, and sometimes longer. I've seen transplants that are sort of 35 getting on for 40 years old. So transplants really are sort of the solution to kidney failure. Obviously, there's not enough donations. There's not enough people that are able to donate. So it's important that all those donations go ahead and are supported as possible. But yeah, if you let's say your kidneys fail, you're in your 30s, your kidneys fail. If you just have dialysis, you might see your 40s, maybe early 50s. On the other hand, if you have a transplant, that transplant you'd hope would last for about 20 years. That gets you well into your 40s. Then you can have a bit of dialysis, then a second transplant, and you're never going to live quite a normal life, but it's getting close. It's not far off. But as we say, kind of diminishing returns as you get further along, further down the list, really. So what about dialysis itself? Well, dialysis, as I say, it's not a miracle, and it's not without its side effects. So these are just a list of some of the side effects of dialysis. So it's pretty grim, actually. It's pretty miserable. Dialysis, it is a burden. And actually, I've heard of quality of life scoring, certainly in the elderly patients with comorbidities, that they're scoring their quality of life being on dialysis with these sort of side effects. They're getting the same sort of scores as patients that are quadriplegic, paraplegic. So it's not great, and it's the sort of thing that you'd certainly have if you're young, really ideally as a bridge to transplant. But as you get older and older, it just is more and more burdensome. I mean, basically, it's exhausting. You have it 4 hours, 3 times a week. The patients, they feel shattered after the session and often into the next day. And really, they only really recover sort of the day of the next session. So, you wake up on your morning of your next dialysis feeling a lot better. And then, 4 hours later, you're back on dialysis to go through it all again. It worsens cardiac function, and that's sort of a big thing, really. There's evidence of cardiac stunning through sort of standard intermittent hemodialysis. It worsens cognitive function. It obviously severely limits your lifestyle, your meals, your drinking habits, and your ability to socialize. So it is it's not a pleasant treatment, but I guess it does increase life. Um, so what do I do in clinic? Well, basically, if you're young and healthy, and I stress healthy, then I'd certainly be advocating for dialysis, and I'd be encouraging patients to do that. Ideally, we'd be heading them down the renal transplant route, because then you have an operation, which is not without its risks, and you take tablets every day, and life pretty much goes back to normal. But yeah, for young people, dialysis, it's not great, but it's not terrible. But if you're 70 and fit, if I see you in clinic, then again, probably heading down the dialysis route, and again, your transplants into those patients sort of 75, and sometimes beyond will get a transplant. It's really when they get sort of 75 years old, 75 to 80, and certainly when they start to get lots more comorbidities, that the line of benefit starts to really become grey. A good 75-year-old, fully mobile with minimal comorbidities, then I'd certainly encourage them that down the route of dialysis. But I'd be stressing these downsides, and if they chose not to have it, then that's fine, really. When you get to 75 with poor mobility, and lots of comorbidities, then I'd sort of strongly been considering them, encouraging them to consider not having dialysis. And then when they're in their 80s, I say it might give people 80, might give people 6 months to maybe a year of dialysis, but the quality of life just plummets. And I'd certainly be not recommending it for most 80-year-olds. But this isn't hard and fast. I do get surprised by these 80-year-olds that are, usually farmers actually, that sort of bounce into clinic, and I think actually you probably would thrive on dialysis. So we'd encourage it, but it's not hard and fast, and it's not without its complications, really. 1 second. So who probably doesn't get dialysis? So this is for you guys, just to if you get referred these patients from the ward, who would I from ITU, who would I not necessarily dialyse from renal? uh, Patients with advanced frailty, and I've had sort of a couple of these referrals even this week on renal. Patients severely debilitated, needing lots of care. The thought of dragging them out of their home to a dialysis unit 3 times a week and leaving them even more exhausted, it doesn't seem like that's much benefit to people. And generally, I wouldn't be offering renal replacement therapy for them. Um, then things like hepatorenal syndrome. So this is always a little bit controversial because they can often be sort of younger patients, but hepatorenal syndrome doesn't generally do particularly well either. Certainly, if you've got ongoing alcoholism and drinking, it doesn't generally end up well. Cardiorenal syndrome, if your heart's failing, if your kidneys are failing because of that, they don't typically do well. And as I've already said, dialysis puts additional strain on the heart, so you're making that heart even weaker. And then multi-organ failure, well, again, in renal, we can only really support one organ, the kidneys. If it's multi-organ failure that they need, we need to speak to ITU. But again, that needs to be sort of thought about in the context of what the illness is and reversibility. So hepatorenal syndrome, as I say, is not good and doesn't have great outcomes. It happens to young people, but overall, it doesn't really end well. If their kidneys fail and they end up on dialysis, then half of them are dead at 6 months' time. Any additional comorbidities and then sort of continuing drinking, makes those outcomes worse, really. So it's again not quite hard and fast, but as a general rule, if a patient's not on a liver transplant list and they've got hepatorenal syndrome, their liver's failing, their kidneys failing, then generally there's minimal benefit from putting them on dialysis. You're just prolonging the death, prolonging the dying process. So it's generally a no from that point of view. And then cardiorenal syndrome. Well, there's at least been sort of bigger studies on this. So as I say, these patients whose hearts are so poor their kidneys are failing. These 3 big studies, they looked at patients that were fluid overloaded, and they compared giving them lots of diuretics, compared that to using basically dialysis or mechanical ultrafiltration to get rid of the fluid. And actually, those that had the mechanical fluid removal, so the dialysis fluid removal, did a lot worse than those that had diuretics. Yeah. And as I said, I've already mentioned dialysis puts additional strain in the heart, and if your heart's so bad it can't perfuse the kidneys, giving it this additional insult of further dialysis will only really make it worse. And sudden cardiac arrest it's not uncommon with patients that start on dialysis with cardiorenal syndrome. So it's again a group that generally avoid dialysing. We do dialyse some. Mortality is not great. I haven't seen exact numbers, but the only ones I can think of have generally died within sort of 6 months or so. So again, mortality is not great. And then the final group really is patients that are hypotensive. Again, we often get these acute kidney injury referrals, and the first thing I look at is nerve center and their blood pressure. And if the patient's hypotensive, there's not a lot we can really do from renal. Obviously, they can be resuscitated, but if that's not working, then they either need to come to ITU for vasoactive support, or that's them generally reaching the end of their life. The problem is that if you go onto dialysis, it's say hemodialysis itself is a suppose you call it fairly aggressive therapy, but you take, a significant volume of blood out of the patient to prime the circuit, and that's 200, 300 mils. If your patient's already hypotensive, taking that blood out can sometimes be enough to cause sort of syncopal episodes or even a cardiac arrest. Um, and yeah, so most patients can't tolerate the standard outpatient dialysis with low blood pressures. Those that do, again, have a fairly poor prognosis. Um, if the blood pressure is sort of 90 to 100 systolic, we can try, and we often do on the renal wards. But it's it's not without its risks. And if it's a temporary problem, we can support it with things like noradrenaline to try and maintain that blood pressure, and we can do things like SLED, which I'm not going to talk about today, but essentially it's a slower, less efficient dialysis that we are doing on ITU. That's a bit more gentle and a bit more cardiac stable. We can do that on the renal wards, and that's sometimes what we do. But again, it needs to be as a bridge to somewhere. If that's the patient's normal blood pressure, then they're not going to thrive on dialysis. So you're going to have poor survival on dialysis if you're greater than 85. If your nutritional status is bad before starting dialysis, this is also sort of a really bad sign. So low albumin for patients with chronic kidney disease starting on dialysis, this is bad. It's a bad prognosis. They're not going to do well. Activities of life dependence. If patients kind of crash land onto dialysis, so we talk about patients that haven't engaged with medical services and things like that, they do a lot worse than those that have been seen in clinic, have had fistulas formed and things like that. And then, as I say, emergencies of inpatient initiation, sort of worse outcomes, and obviously those comorbidities we talked about. So final slide, really. This dialysis is not a miracle cure. It's not a great life. It's a pretty awful life, actually. The older you are, the less benefit you get. Heart failure, liver failure, multi-organ failure, they don't do well on dialysis. So I'll finish it off there. It's been just over an hour. I will stop sharing, and let's see if there's any questions. Lovely. Okay. I hope that's been useful, everybody. Thank you I know technical difficulties are a consistent thing with MS Teams, but yeah, if there's if there's ever any questions, just drop us an email. Happy to answer questions about things. And yeah, thanks very much for attending, everyone. Thanks very much.